Welcome back to the deep dive. Today we're looking right at the center of the face. Literally, we were talking about the nose. But before you tune out, thinking this is going to be some shallow conversation about vanity or nose jobs, let me just stop you right there. Because the source material we're digging into today, this specialized surgical textbook chapter on rhinoplasty, it paints a totally different picture.
It really does. It frames the nose as this incredibly complex anatomic unit. It's this high-stakes meeting point of aesthetics, psychology, and vital function.
Breathing and smell.
Exactly. It's not just a block of clay you can sort of push around.
Not at all. And our mission today is to decode this chapter. We're going to peel back the skin, metaphorically, of course, and look at the structural engineering, the physics of the skin, even the optical illusions that surgeons have to master. It felt less like a medical text and more like, I don't know, a manual for civil engineering.
That is the perfect analogy. I mean, you're dealing with structural supports beams, struts, you have valves that control airflow, and biological materials that have their own, memory.
Right.
And if you treat them wrong, they will fight back.
So, okay, let's start with the canvas itself. The skin, I think most people, myself included, assume the skin on your nose is just skin, a uniform wrapper. But the source material makes a huge deal about thickness variability. It's not consistent at all, is it?
Not even close. And if a surgeon doesn't get that, they can't paint the picture. The text breaks it down with these really specific measurements. It says nasal skin is actually thickest at the radix.
And the radix is the root of the nose, right? That little dip between your eyes.
Correct, yeah. The skin there is about 1.25 millimeters, which sounds small, but in facial anatomy, that is significant. But then as you move down the bridge to the rhinion,
The bony part in the middle.
the bony cartilaginous junction, it thins out dramatically.
The text says it drops to just 0.6 millimeters. That is
Paper thin. It really is. And then, just to keep things interesting, it gets thick again right at the tip, especially in that super tip area with all the sebaceous gland.
the oil glands. Okay, so you have this thick transition. The text had this analogy that really stuck with me. It compared the thin skin to a silk sheet and the thick skin to a heavy wool blanket.
That's the classic teaching tool. And think about what that means. If you have a patient with thin skin, that silk sheet, every tiny little imperfection, every rough edge of bone you leave behind, it's going to show right through. It camouflages nothing.
It's totally unforgiving. But then, isn't the thick skin easier? It hides mistakes, right?
It hides minor stuff, yes. But it also hides your work. That's the heavy blanket problem. You can do all this incredible, intricate stitching underneath, refining the cartilage to get a sharp tip, but if you throw a heavy blanket over it,
None of it shows up.
none of that definition shows. So with thick skin, you often need much stronger structural support just to push through that skin envelope. It changes the whole plan.
Okay, let's go deeper. Literally, beneath the surface, we have to talk about the layers. The text mentions something called the SMAS. SMAS.
The superficial musculoponeurotic system.
Right. Glad you said it, not me. Sounds like a secret society.
It's basically this continuous fibromuscular layer. It wraps the face and extends right into the nose. But what's so fascinating here isn't the layer itself, it's what's just beneath it. The text points to an avascular plane.
A vascular, so no blood vessels.
Virtually none. It's this perfect zone, right below the SMAS and just above the cartilage frame.
And that, I'm guessing, is exactly where a surgeon wants to be.
It is the holy grail of dissection. If you can stay right in that plane, you get a bloodless field. But if you go too shallow or too deep, you hit the vascular network.
And then it's a mess.
Then you're dealing with hemorrhage, it just obscures your view, you can't see the delicate structures you're trying to fix, and it leads to massive swelling after surgery. So finding that plane isn't just about being tidy, it's about precision.
All right, let's talk about the structure that holds it all up. The text uses a concept that I found super helpful for visualization, the tripod concept.
Oh, this is foundational for understanding the nasal tip. Just imagine a camera tripod. Two of the legs are the lateral crura.
Those are the cartilage wings that shape the nostrils on the sides.
Exactly. And the third leg is the medial crura, which is basically the columella, that strip of skin and cartilage between your nostrils.
So you have two legs spread out and one leg pointing down.
Precisely. And just like with a camera tripod, if you shorten or lengthen one of those legs, the angle of the whole platform, the nasal tip, it changes completely.
So if a surgeon wants to rotate the tip up, give it a bit of a lift, they're literally adjusting the length of those legs.
That's exactly it. You shorten the lateral legs, the tip rotates up, you shorten the medial leg, the tip drops. It's pure trigonometry. Surgeons use this to predict exactly how the nose will sit.
But a nose isn't static like a tripod. This was a surprise. The text lists all these muscles, elevators, depressors, compressors. I didn't realize how much the nose moves,
We forget that, the nose is dynamic. There's a muscle called the levator labii superioris aliquinasi.
which is Latin for lifter of the upper lip and nose wing.
You got it. That's the muscle that scrunches your nose. But the one the text really warns surgeons about is the depressor septi.
The depressor, so it pulls things down.
It sure does. It connects the lip to the septum. And in some people, this muscle is hyperactive, so when they smile, it pulls the whole nasal tip downward.
Wow. So you could have a nose that looks perfect at rest, but as soon as you smile.
The tip just dives. We call it a plunging tip. A surgeon has to assess that movement. Sometimes they even have to surgically cut or modify that muscle to stop it.
That brings us perfectly to the blueprint section, the assessment. The text really emphasizes that you can't just look at the nose in isolation. It talks about this paradoxical relationship it has with the chin.
Yeah, this is where we get into optical illusions. The text explains that an overprojected nose one that sticks out too far can make a perfectly normal chin look weak or recessed.
Just because the brain is looking for balance.
Right. And the other way, too. If someone has a really small, weak chin, it can make their nose look huge, even if the nose is mathematically average.
So a patient might come in wanting a smaller nose, but the surgeon realizes the actual issue is that they need a chin implant.
Or at least the surgeon has to explain that just fixing the nose won't balance the profile. It's a jaw issue, not just a nose issue.
Speaking of aesthetics, the text mentions this ideal for the tip. It calls it the gull in flight.
This is a classic visual. If you look at someone straight on, the line formed by the rims of their nostrils and the tip should have this gentle curved shape, like a seagull's wings.
So not a flat line and not a sharp V.
Exactly. It needs that soft undulation. If it's too flat, the nose looks boxy, too arched, and it looks retracted.
But it gets even more specific than seagulls. The text brings in actual math. Goods ratio.
Can't escape the math. Goods ratio is for checking tip projection. You measure the distance from where the nostril meets the cheek out to the tip. Then you measure the height of the nose from the nasion, that tip between your eyes, down to the tip.
And you just compare those two lines.
You divide the projection by the length, and ideally that ratio should be between 0.55 and 0.60.
So there's actually a golden ratio just for noses?
In a way, yeah. If the number is higher than 0.60, the nose is overprojected for its length. If it's lower, it's underprojected.
And to measure all of this, the text insists on standardized photos using the Frankfurt horizontal plane.
Oh, this is crucial because angles lie. The Frankfurt plane is a standard line from your ear canal to the bottom of your eye socket. Your head has to be perfectly level.
Why does that matter so much?
Because a deep radix, a deep dip between the eyes, makes a nose look short. A shallow radix, where the bridge starts really high, makes it look super long. If the patient tilts their head even a few degrees in the photo, all those measurements are thrown off.
The camera doesn't lie, but the angle can't.
That's it.
Okay, let's get into tactics. The surgery itself. The text outlines this massive debate in the field. Open structure versus endonasal, or closed rhinoplasty.
This is the great divide. Every surgeon have a preference, but the text lays out the specific reasons for both.
Let's start with open. That involves a specific cut, right? The transcolumnar incision.
Yes, it's this little stair-step incision across the skin between the nostrils. That cut connects with incisions inside the nose, and it lets the surgeon do something called decortication,
Which is a fancy word for it.
lifting the entire skin hood of the nose up. You're basically degloving the framework.
That sounds intense. But I assume it gives you a view you can't get any other way.
It gives you binocular vision. You can see the entire skeleton of the nose right there. The text says it's essential for, say, a complex reconstruction or major asymmetry because you can see the problem and stitch grafts with total precision.
But there's a catch. There's always a catch.
2 catches. 1, you leave a visible scar, but when it's done well, it's very hard to see. And 2, because you've disrupted so much tissue and the lymphatic drainage, you get more edema, more swelling.
And that swelling can last a long time, right?
It can take a year, maybe more, for the final definition to really show up because of that.
Okay, so what's the alternative? The closed approach.
The endonasal approach. All the incisions are hidden inside the nose.
The pros seem obvious. No scar, less swelling.
Faster recovery for sure. But the text describes it as having a steep learning curve.
Why is it so much harder?
You're operating through a tiny tunnel. With monocular vision, you lose depth perception. A lot of it is done by feel rather than sight. It's incredibly difficult to place complex grafts when you can't just open the hood and look.
So open is like opening the hood of the car, and closed is like trying to fix the engine through the tailpipe.
That's a bit of an exaggeration, but the logic holds. The closed approach preserves more of the natural support mechanisms, but it demands a surgeon who really knows their anatomy by touch.
Speaking of fixing things, sometimes you need spare parts. The text has a whole section on grafts. I always thought rhinoplasty was just about taking stuff away, shaving bumps. But the text says modern rhinoplasty is often additive.
That's a huge shift in thinking. We used to just reduce.
Right.
That often weakened the nose. Now we know we often have to add material to build support.
And the gold standard for that material is the septum itself.
Septal cartilage, yeah. The text says it wins because it's firm, it's flat, it's resilient, it's like high quality plywood for construction. Plus you're already in there, so it's right there.
But there's a limited supply. You can't just take the whole thing.
Exactly, you have a finite amount of it. So if you run out, or maybe the patient had a prior surgery and it's already gone, the text says you go to the ear, auricular cartilage.
But the ear feels so floppy compared to the nose.
It is more elastic, and crucially, it has elastic memory. It's naturally curved.
So it wants to curl back up on itself.
Yes. It's great for recreating the curved shape of a nostril rim, but it's terrible if you need a straight, rigid beam to support the bridge. It'll just warp over time.
So if you need a rigid beam and you're out of septum.
Then you go to the rib, costochondral cartilage.
That sounds painful.
It is. I mean, it's a second surgical site on the chest. It's an abundant supply. It's very strong, but it's more invasive.
The text also mentions synthetic stuff, alloplastic implants.
Yeah.
Why not just use plastic? Seems easier.
The text is very cautious here. It mentions silicone, which is easy to carve, but the body reacts by forming a fibrous capsule, basically a scar tissue bag around it.
So it never really becomes part of the nose.
No, it just sits in a pocket, which means it can move, or worst case, it can extrude. It can push its way right out through the skin.
That is a horrifying image.
Then you have medpore, which is porous, so tissue grows into it, which anchors it. But the text warns it is very hard to remove later if there's a problem. You're basically chiseling it out.
Wow. So your own cartilage is always the best bet. Let's get into the specifics. The thing people usually want fixed. The hump.
Dorsal hump reduction, the bread and butter. But the text makes a really important distinction between a true hump and a pseudo hump.
How can a hump be fake?
It's all about relation. Let's say the tip of your nose is underprojected, it's too close to your face. That can make the bridge look like it has a hump, even if the bridge height is totally normal.
So if you just shave down the bridge, you'd end up with a tiny scooped out nose.
Exactly, with a still weak tip. The real fix would have been to bring the tip out to meet the bridge. Diagnosis is everything.
But if they do need to break the bone, the text describes a technique that sounds weirdly delicate.
It's a postage stamp method. I love this visual. It's called the percutaneous technique. In the old days, they'd use a hammer and chisel, but this method uses a tiny 2mm microosteotome.
A tiny chisel.
It is. And the surgeon makes a series of little punch holes in the bone, just like the perforations on a stamp.
Okay.
And then, with a controlled movement, the bone breaks exactly along that dotted line. It's incredibly precise and minimizes trauma. Prevents that shattered look.
It really is construction work. Speaking of which, we have to talk about the foundation, the septoplasty.
The septum divides the nose left and right, and it is almost never perfectly straight. Can be crooked from birth, trauma.
And the text specifically calls out drug misuse.
Yes, it mentions that cocaine is a vasoconstrictor. It shuts down blood supply. If you use it chronically, it can destroy the blood supply to the septal cartilage and cause a perforation, a literal hole.
Yikes. Regardless of the cause, if you're fixing the septum, the text says there's a key area you absolutely cannot touch.
The L strut. This is crucial. Imagine an L-shaped beam of cartilage. One leg of the L runs down the bridge, the other runs along the columella.
So it frames the nose.
Exactly. You can take out the cartilage in the middle of that L, straighten it, or use for grafts, but you have to preserve at least a 1 centimeter wide strip of that L strut.
If you don't, if you get greedy,
the whole thing collapses. You get a saddle nose deformity. The bridge just sinks in. That L strut is holding up the entire tent.
that leads to the final big concept in the text, function. We've talked so much about shape, but the text ends on the internal nasal valve.
This is where form and function just collide. The internal valve is the narrowest part of your airway. It's the angle between the upper lateral cartilage and the septum.
And what should that angle be?
Ideally, about 10 to 15 degrees. If a surgeon narrows the nose too much for aesthetic reasons, trying to get that super slim, pinched look, they can accidentally close that angle down.
And the patient can't breathe.
Exactly. And it doesn't matter how good your nose looks if you have to mouth breathe for the rest of your life. The text is just adamant. You cannot sculpt a nose without respecting the valves.
There was one final point in the text I found really provocative. It wasn't about anatomy,
Yeah.
but psychology.
Yes. The text advises surgeons to document everything beforehand, including things like headaches or sinus issues.
Because if they don't,
Patients will often blame the rhinoplasty for headaches or sinus problems that they actually had before the surgery.
that is fascinating. It suggests that once we change something on our face, we hyper-focus on it. We sort of lose our baseline.
It raises a really important question for you, for the listener. How much of our satisfaction with our face is physical, based on millimeters and angles, and how much is just purely psychological expectation? A surgeon can fix the deviation, but they can't always fix the expectation in the mind.
That is something to think about next time you look in the mirror. You're not just looking at a nose, you're looking at a marvel of engineering, skin physics, and psychology, all balanced on a tripod of cartilage. That's it for this deep dive. Thanks for listening.
Ideally, we'll see you next time.